Fighting Blindness Canada's Viewpoint is a virtual education series that brings you the latest in vision research presented by health experts from across Canada. The webinar you're about to watch is a recording. To learn more about the research we fund and upcoming webinars and events, please visit our website at fightingblindness.ca. This Viewpoint webinar is proudly presented by Bayer and supported by Abbvie, AGTC, Apellis, Janssen, MeriaGTx, Novartis, and Roche. Thank you for watching. We hope you enjoy this webinar and share your thoughts with us in the comment section below.
So to introduce Dr. Sheidow, I'm sure actually many of you on the call know him already and have heard him speak at other events. But Dr. Sheidow is an associate professor of the Department of Ophthalmology at Western University in London, Ontario. His major clinical and research interests are AMD and macular diseases, and he has been a participant in many of the major AMD and diabetes clinical trials over the recent years. So for instance, he was co-chair of the Canadian trials that evaluated Luminescence versus laser for diabetic macular edema. And he also was part of the Treat and Extend regimen for Lucentis called CAN-TREAT, which was looking at age-related macular degeneration. And Dr. Sheidow's current areas of interest are AMD and teleophthalmology, so perhaps we'll be able to sneak in a question about that as well. And we actually got a message from one of our community members on Facebook when we advertised this event. And he sort of just was raving about Dr. Sheidow, who had looked after his ears and the damage. He said his eyes have been damaged due to diabetes, had a lot of procedures over the last couple of years, but he felt he couldn't have got better care from Tom and the team at Abbvie. So I just wanted to share that with you, Dr. Sheidow, before we got started.
Thank you.
Yeah, so we are going to sort of do the similar format we do in some of our other sessions, where we've got a number of questions for Dr. Sheidow, and then we will take a pause and then open it up to essentially to the floor. So if anybody has any questions, please start thinking about them, popping them into the Q&A, and we'll get to, as I said, as many as possible. So to start with, sort of to level set us all, I was wondering, Dr. Sheidow, if you could give us a brief overview of what age-related macular degeneration is. And in particular, I know there are the two forms of it.
Sure. Well, I mean, and any of the people who've had the misfortune of meeting me in the past realize that I think the way to always think about macular degeneration is a combination of things, but it initiates in the fact that you've had too many birthdays. It tends to be a disease of older people, and that's why we see the prevalence of macular degeneration go up exponentially over time. With society and people living longer, we're seeing more and more of this disease. And so what it really is a combination of a wearing out of the macula in people's retina, combined with a few other factors that, although I say genetic, I don't mean that there's a single genetic test we can determine who's going to get it, but it's clearly a disease that runs in families to a degree. And so we're looking at a disease which is more common as we get older, that affects up to 1/3 of the population over 75, and has a hereditary component to some degree, which we'll probably talk about a little bit later on in the discussion. What happens at first is the pigment cells, we call them the retinal pigment epithelium, they start to become a little less functional. And since their real job is to clean up after the retina sees, the retina is a real workhorse. It does a lot of work dissipating and taking in the light and then creating an energy to send to the brain. And those retinal pigment epithelial cells have to dissipate the heat and get rid of all the waste products. And as they become less functional with age, we get a collection of things called drusen, which are something your optometrist or ophthalmologist will be able to see at the back of the eye. And it's the first sign of macular degeneration. It's not something we can treat, it's not something we can stop, but it's a way of knowing that you have the disease. And then as it progresses, and not everybody's will, but it can progress, as you alluded to one of two forms. There's the exudative or wet form of the disease, where a little blood vessel grows like a weed grows through the crack in the sidewalk. A little blood vessel grows through a little weak area and starts to leak and bleed, taking away the vision very quickly. And then there's the non-exudative or dry kind that can be very mild and almost seemingly non-progressive, or we can develop what's called geographic atrophy, where there's big patches of pigment cells that are lost. And up until very recently, there's been no therapy for that, but I know we're getting to that later on today. And so that's how I think of the two. There's a slow kind of deterioration and there's a fast kind. And they're not better and worse. They're just different. And they, up until now, have been treated different.
So actually, just a couple of things from what you were talking about. So when you talk about the drusen, is the drusen harmful to the eye, or is it just essentially a symptom that something is happening?
I think they're mainly an indicator that the retinal pigment epithelium, or what I'm going to call the RPE, that's how we usually speak of it, that the RPE in the area of the drusen are not as healthy as they should be. And so they don't specifically cause vision changes, but they're a sign of the local pigment health. And so they're a good indicator that something isn't working as well as it should. So
Okay.
they are not themselves the problem that people notice in their vision.
Mm-hmm.
And many people have lots of them and don't even know they could be 20/20.
Oh, that's interesting. And then in terms of progression, when you see a patient maybe for the first time, is there any way that you as a clinician can tell if somebody's going to progress faster or slower, or maybe progress to the wet kind?
No, I always think that that's a mistake to prognosticate. What I think is important is you've got to determine if it's dry or wet, because if it's dry right now, there's no treatment. But if you look at the rates of turning wet, if we want to call it that, because really one of the things that's a mistake is to not emphasize to people that just because you have dry macular degeneration now, doesn't mean it'll be dry 6 months from now. And when you turn wet, it doesn't mean the dry went away. The dry is still there doing its work. And so they're really two separate processes. You can have both going on at the same time. And to your point, what you find is that if there was 100 people with macular degeneration, about 10 to 15% have wet and about 85% have dry. And so the vast majority of people have the dry kind. And for those people, the most important thing is, and many people probably have one already, what's called an Amsler grid. It's a piece of graph paper. Just taking the time to check their left eye and check their right eye once a week to make sure they know how well they see, because what they're looking for is a rapid change in their vision that may be the conversion to the wet, but you really can't predict how quickly it's going to happen. And most importantly, if you see a change, you should just get it checked. You shouldn't try to guess. Just go into your optometrist and get it checked right away.
I feel like that's the lesson I try to tell when I'm talking about AMDs. If you see a change in your vision, definitely go to your doctor as soon as possible.
Yeah, especially in today's world where the ability to get an optical coherence tomography or an OCT is so much different than it was 20 years ago. We can very quickly and non-invasively pick up the wet changes. And so it really has become an easier thing to do in almost every optometry office or ophthalmologist office. They're very much more common than they were years ago.
Okay, I'm going to get us back on track so I don't, I've got so many more questions just from the few things you said. So we were going to move on to talking a little bit about the different treatments for the different types of AMD. I was wondering if we could start with wet AMD. So if you could just tell us a little bit about what some of the sort of treatment standards of care are.
Well, and one of the talks I give, Larissa, that, I've been fortunate that when I first came back to London now 22 years ago, we didn't have any treatment other than blasting things with the laser. But what's really been interesting and nice for me is that I've been able to sort of see the evolution of care over the last 23 years, and it's been phenomenal. And what really happened was around the time I came back was when the first drug for treatment, which was called photodynamic therapy, was a drug called Visiodine. And it was a drug that got injected into your veins, and then we turned it on with a cold laser. And although that drug wasn't good at restoring vision, it was the first time that we could treat wet macular degeneration without losing more vision. And so between about 2001 and 2006, that was the only therapy was available. And then what somebody who's very observant notices that when we were treating people with a form of anti-VEGF for colon cancer, they saw that macular degeneration patients were getting better. And so that was sort of the days that Avastin, Lucentis, now Eylea, BioVIS, and Faricimab all came on market. And what they are is they're called anti-VEGFs, and VEGF stands for vascular endothelial growth factor. It's basically a little fertilizer for blood vessels to grow. And so what all these medicines do is they stop the push for blood vessels to grow, and they also make those abnormal blood vessels less leaky. And so they have a double benefit. And so all of these agents are injections. So it's a needle in the eye, and they all work in a similar manner. They're different compounds, but their main effect is blocking that growth factor. And so that's really been the mainstay of treatment. And if you look at my practice in 2006 and my practice today, by far and away, the problem has been, and it's a good problem, is that we now have a treatment for macular degeneration. And it's nice because this same treatment works for diabetics and blocked veins, but this treatment is an ongoing need. And so what I also tell my macular degeneration patients when we first start is the injections are meant to be for life if we have vision to protect. And so it's not that I'm curing them, I'm controlling the disease. And so usually what we do with any of these agents is we do a once-a-month needle for 3 months. The idea is to aggressively get the swelling gone, get the blood vessel under control, and then after that, there's different approaches. Some people believe in keeping the once-a-month going forever. I don't happen to, but that doesn't mean it's wrong. Other people believe in stopping and starting. I'm very much a believer that what you don't want to do is allow the retina to get swollen and thin like an accordion. And so I'm a big believer in that. One study you mentioned was a Canadian attempt to deal with the Canadian volume problem, and that was called treat and extend. And so what we do is once we get the retina stable, we treat patients and we add a couple of weeks to their time to see if they can go a little longer between needles, hoping that we get a more balanced approach where they're not coming in every month, but they're keeping the disease from getting worse. And it works really well in most people.
And do you find that it's very different time frames for different patients, or is there a rough, like 3 to 4 months that most patients can move to?
I would say that for most people, we cap the length of time at about 3 months. So very few would you let go beyond, but that may change with some of the newer agents. And very few people stay on the once a month. And so the nice thing is we're not having to inject people 11 or 12 times a year. And I would say the majority of people, not everybody though, and those are the ones I'm hoping the newer agents will get approved and available for, but most people you can get them out to, 9, 10, 12 weeks between shots, which is a lot more tolerable for people.
Mm-hmm. And I think that's actually a perfect segue talking about some of these newer treatments. I was wondering if you could sort of share what you're sort of excited about seeing in the wet AMD space, whether that's other types of anti-VEGF or other types of treatments.
Well, there's certainly been, right now, I would say that probably in all people's practices, Eylea and Lucentis, which are the two mainstays of therapy, are what you'll find that most patients get, and they work very well. A therapy came out a couple of years ago that was touted to last a little longer, but it had a couple of risks that we decided it just wasn't enough of a benefit to go to. But a new agent has come out in the last 6 months or so called Vabysmo. It's a new product that is touted to last a little longer, with hopes that we might be able to push some people out to 4.5 months between shots. It has a slightly added benefit that it also attacks a second aspect of one of the growth factors. And basically the problem we're faced with right now is in most of the provinces, a drug being approved doesn't mean it's covered. And so for many people, you don't want to take them off a drug that is covered for them and working to try something new that they have to pay for. And so that's one of the hurdles we're going to see in the near future, is waiting for that to become covered. Similarly, the Eylea people have been trying a higher dose form of Eylea with the hopes of extending its age. And that seems to be also showing some promise that a smaller concentrated version of it might enable us to stretch people out to 4 months again. A product came out that was a depot. And what I mean by a depot is it was a little reservoir that gets surgically implanted in the eye and then gets refilled every 6 months. there was a lot of hope, I think, from some people in that. But my personal thought is that I don't see it being a good thing for the Canadian market for a couple of different reasons. One is it's a surgery to implant this. And so with any surgery comes other complications and problems, and it also becomes a bottleneck in the obtaining therapy. And so I have a feeling that that idea, although some patients may have read about the depot, I don't think you're going to see it really come to fruition, at least not in Canada. And then there's always new things in phases 1 and 2 that are wonderful. And I think probably, if you ask me, the thing that we're all hoping that'll come along is something like one of the viral vectors. So what we mean by a viral vector is we've all had the cold. And I really mean the cold. I don't mean COVID. And the cold virus is wonderful because it's a virus that our body has seen and has dealt with many times in the past. But you can sometimes change the genetics of a virus to produce something positive instead of something negative. And when we do that, we call it gene therapy. And so what would be wonderful is if we could train a virus that doesn't have any harmful side effects inside the eye to make these anti-VEGF products so that you do an injection and it just keeps on making and making and making on a recurring basis the product you want. And so I think that one of the hopes is, and it's still in early phases, that we can get a version of a gene therapy for macular degeneration. Nowhere near a TV show coming to you, but it's on the horizon of things that people are trying.
So are there gene therapies currently in clinical trials that you
There
know
are.
about? Oh, okay.
There are. Some of them are surgically implanted under the retina.
Mhm.
Some of them are trying to come from an outside the eye around to the back approach. But right now, they're more of a surgically deposited compound as opposed to a simple injection into the center of the eye. But there are therapies going on. I think I'd be wrong if I didn't call them phase 2 studies. And so usually in a phase 2 study, they're small groups of patients. They're looking for both efficacy, but mostly safety. And so seeing something is safe is the first step before they roll it out to a larger trial. And so there's still a ways away from being something that people want to be looking for in their Google searches. But there are phase 2 studies going on right now.
And I was just thinking back to when you were talking about how anti-VEGFs first entered the market for AMD, and it was seeing the impact of from cancer patients on AMD. So I think I know the answer to this, but why do you have to inject the treatment into the eye? Why can't you do, say, an intravenous treatment then? Well,
and it truly was a colon cancer medicine called Avastin that was first noticed to help. And the reason that I think you've always got to be careful, and that's why so many of the drug companies are careful. I mean, no one can be perfect. No one can know all the possible complications, to their credit. But as soon as you deliver something in an intravenous route or by mouth, intravenous means it's going to go out throughout your whole body. And so what you're going to do if you put an anti-VEGF into your veins is you're going to then stop the development of blood vessels all over your body. But that's part of natural healing. When you cut yourself, you need tissue to heal by scarring together and then growing new blood vessels to feed that new tissue. When people have strokes, you need blood vessel to grow in to nourish the new tissue. And so it is a concern that you stop VEGF everywhere. Similarly, when you take a pill, whenever you take a pill by mouth, it gets absorbed in your gut, and then it has to pass through your liver. And your liver is wonderful at filtering out toxins. And so sometimes the problem with some of these things too is that the efficacious part of the medicine gets dealt with by your liver or doesn't get absorbed in your gut, and so you don't get enough of it. And so there's other side effects that need to be evaluated. They're looking at agents, they're hoping to find something that can be given in a lot nicer way, but they're wanting to do it safely, because when Avastin was given intravenously, they saw more risks of gastrointestinal bleeds and high blood pressure that was a lot worse. And so you always have to be careful to not make a patient worse overall just to save their sight.
Mm-hmm. So balancing some of those risks and benefits, I guess.
Yeah,
Mm-hmm.
yeah.
So that was wonderful talking about wet AMD. Just looking at the time, I think I might move on to dry AMD now. I know you mentioned at earlier in the talk how there currently aren't any approved treatments for dry AMD. So I was wondering if you could tell us sort of what's on the horizon in that space.
And I probably misspoke earlier when I said there's nothing I can do. One of the things we all forget is that the National Eye Institute in the US ran two very big, wonderfully done studies looking at vitamin and mineral supplementation. They were called AREDs. And basically those studies proved that a combination of minerals and vitamins, including not only lutein, is helpful to the eyes. And so I think for anybody who is diagnosed with macular degeneration, taking those vitamin supplements, the regular run-of-the-mill kind of vitamin supplements, not some expensive esoteric vitamin supplement, is healthy for the eye, and it helps slow down the process. It doesn't cure anything, it doesn't fix anything, it doesn't make your vision better, it's just meant to slow down the process. And what the belief is that it's slowing down the deterioration of those pigment cells. But what's coming, and I think it's wonderful, is that two of the companies, one literally, as you and I were talking about just before we started this, got FDA approval in the US last week. And so hopefully will be approved here in Canada over the next 6 months. And the other is very close to filing in the US and Canada. And these are treatments for what we call geographic atrophy. When you look at someone's macula, and if you think of it like a bullseye, with geographic atrophy, people start to get these little areas, and they're often patches where the pigment is lost. And those patches over time are known to grow bigger and bigger and eventually grow together. And so what these therapies are for is not to restore the pigment that's been lost. And so they won't restore vision in people who have lost their vision to dry AMD. But they're meant to slow down the progression of these areas called geographic atrophy. And they've shown to have some very big and positive impacts on the rate of growth. And what I think of as even more important, and it's the same for both agents. So I'm not saying the one that is approved is better than the one that hasn't been approved yet, because they're just at different phases. But both of them are showing that if you follow a patient for a year, you see a benefit. In the one that just was approved, if you then look at that same patient at 18 months, there's more benefit at 18 months than there was at a year. And at 2 years, there's more benefit than 18 months. And so what you're seeing essentially, Larissa, is the curves continue to get farther and farther apart. And so it's the ongoing therapy which is continuing to offer a benefit to patient. You can look at it from the patient's perspective that you're not curing anything. And that's true. And so again, this is a therapy that, if it's going to help you, is a therapy for life. But because of this increasing effect over time, and the fact that we know that geographic atrophy can be as devastating for someone's central visual acuity as wet is, meaning it can take away all your reading, it's a really big step forward that we're going to have a new therapy. The only problem, as most of us will agree, is that it's also an injection in the eye. And again, that's a safety thing. Right now, we know we can relatively safely do that. But it's going to become, again, a big burden on patients and a big burden on the clinics to get these people in, screened, and on treatment. But it's really, really wonderful that we're going to have this therapy hopefully soon.
And so this treatment, the first one at least, is currently approved, just got approval in the States, hopefully in Canada in the next year or so. Would that be for anybody with dry AMD, or would it only be for individuals who have more advanced dry AMD?
I think that what it'll come out, and I haven't been able to see what we call it, the label. When a company gets a new drug approved, Health Canada will have a label indicating who's supposed to get it. And it usually isn't exclusive, but as of right now, the people that are allowed into those studies have been people with a specific kind of dry, and it's with geographic atrophy. And so, no, the majority of dry AMD patients wouldn't be eligible, nor would they want to put themselves through the risks. Because remember, there's always a risk of an infection or a retinal detachment from macular degeneration injections. And so you wouldn't want to treat somebody who doesn't have any of the risk-benefit ratio in their favor. And so it wouldn't be for everybody. It's only for people with geographic atrophy.
Okay, that's clear. So this sort of actually might answer one of the questions we got from somebody who wrote in earlier, but do you have advice for people who are currently living with age-related macular degeneration and are waiting for some new treatments to become available?
Well, I think that if you're living with it and not under someone's care, and I don't mean a retina specialist or anything, I just mean if you're not having regular checkups, that's the biggest mistake right there. Some patients of mine where the wet was caught too late to be of benefit in that eye, I strongly encourage them that 2, if not 3 times a year, they should be seeing their optometrist or having a checkup to ensure that the other eye doesn't turn wet. Because what we know in people who get wet in one eye is they have a 50% chance of getting wet in the other eye. And so watching is very important. The same goes for people with dry, and it depends a little bit on the stage of their dry, but it's really important to keep themselves in, I don't want to say in the know, but at least being regular checkups a couple of times a year so that if something becomes available and they're going to be a candidate, they can get into the potential treatment pipeline.
Okay. Jackie, I was wondering, is Susan around? I was going to turn to Susan and give, oh, there we go, perfect. So Dr. Sheidow, thank you. That was sort of like the formal part of the session. I'm going to give you a 5-minute break while Susan tells our audience about some exciting events, and then we'll get to the audience Q&A after this, and I can see them pouring into the Q&A below. Susan, are you there? We can't see or hear you, Susan, so I'm not too sure. There we go.
Here I am.
Perfect.
Sorry about that.
No problem.
There we go. Hi, thanks so much. That was an excellent, excellent presentation, Dr. Sheidow. Thank you so much for joining us. Yeah, so Larissa is throwing it over to me to talk to you guys a little bit about what some of the exciting fundraising events are coming up for Fighting Blindness Canada this year. And there are so many ways that you can get involved and join us. And as you know, raising funds for critical vision research is our mission, and we can't do it without the help and the support of people like you. We have a number of opportunities this year. We've got coming up pretty quick is our Cycle for Sight event. I'm going to talk about all of these in a little bit more. Comic Vision is our incredible comedy night, coming together, sharing a cocktail or two, and having some laughs. Ride for Sight, of course, is our longest running event. It is our motorcycling event. Screens Off for Sight, Eye on the Cure, and Sight Savers will all be happening in the fall as well. So there are lots of opportunities coming up to get involved. And a little bit about Cycle for Sight. We're asking everyone around Canada to join in the movement of helping us raise money and funds for vision research. We've got a number of different opportunities for you throughout Canada. Starting off on June 3rd, starting the cycling season on June 3rd will be our in-person Toronto event in Alliston, Ontario, and also on the West Coast in Vancouver and Langley, BC. That's going to be a wonderful cycling event that's open for people of all ages. It's a great day to come out. We'll have different lengths of routes that you can cycle, recreational cyclists as well as good high-end cyclists as well, tandem tandem cycling as well. In Alberta, Calgary area, we're going to be piloting a walk tentatively scheduled for the end of June on June 24th in that area. In Ottawa and in Paradise, Newfoundland on July 9th, we will be doing a cycle and a walk component. We're adding a nice walk component to those cities. So we're going to have our cyclists go one way and our walkers go the other. So those of you who don't get on the cycle and ride 100 kilometers a day, like myself, we will have a walk option for you. Very relaxed 5-kilometer walk. And the idea is to come out, have a great time, do some fundraising, share it with your network and your friends and family, and just come and join us for the day. There's also the virtual event. So if you don't cycle and you don't walk, or you're not in any of those areas, you can still participate and join us at our Cycle for Sight virtual. We had a number of people during the COVID years that did this, joined us in Cycle for Sight virtually, did yoga in their home, went out for their own walks, did swimming. So there's so many ways. We just want you to get together and move with us and move vision research forward. And our next slide is our Comic Vision event. So that one is coming back again. This one this year in Toronto on Thursday, May 11th, is our cocktail edition. So it'll be a little bit less casual. It's not your typical gala. It's not a chicken dinner gala. It's going to be very casual, but still sophisticated, if you will, with comedians and lots of fun galore. In Calgary, we're working on June. It might be in the fall. That one will be at a local comedy club there in Calgary. In Vancouver and Montreal, our dates will also be in the fall, and those are coming soon. So stay tuned for more information on that one. That's our comedy night. In August and June, July, and August this summer, our motorcycle ride is back. And that one is, if anybody you know rides a motorcycle, they are welcome to join us at our rides in Fenelon Falls, in Calgary, and in Gander, Newfoundland. Again, another way to join the movement and have some fun while fundraising for vision research. The websites are on all of these slides for each of these events. In the fall, we're going to have Screens Off for Sight, and that's a new event for us a little bit. That one's going to be on World Vision Day on October 12th, and we're asking everyone to fundraise by turning off your screens for just 4 hours on that day. Give your eyes a rest. Get your friends and family involved, go for a walk, just do some things that just not on the screen. We all know that enhanced screen time is not that great for our eyes. So we want to ask you to just give yourself a break, turn your screens off, and let's talk about the importance of eye health on that day. In November of this year, we're coming back with our researchers competition online. If you're a fan of Dragon's Den, you're going to like this one. This one is we get our, we throw out some competition to our researchers and ask them to apply, and then they present their research to a panel of judges and to those of you online, where you get to cast your vote for your favorite vision researcher, and then they are awarded prize money at the end, which is wonderful. It's a great show to watch. Of course, our Sight Savers is always there year round. If you just wanted to have a bake sale, a car wash, or you want to do your own birthday dinner, we invite you to create your own fundraising website. We've made it really easy for you at our Sight Savers website, and you can then use that portal to send out emails to your family and friends to ask for donations to support you in your efforts. We've tried to make it really, really easy, and that's at fightingblindness.ca/Sight Savers. Of course, there's so many ways, as I've said, if you're not a cyclist, you don't ride a motorcycle, you're not going to do any of those other events, all we're asking is just share these events with your network. Think about your circle and family of friends. Talk about the cause, talk about the events. You can connect us with anyone who would like to show their support as maybe a corporate support as a partner at one of the events, or you could share a little bit of your time on an event planning committee. If you are talented or know somebody who's a great artist or creative person and they have items that they've created, artwork or items that might do well in the auction, connect us. We'd love to have that. Prizes on event day and donations of things like that are always welcome. And of course, if you just want to come out and lend us a hand on event day, we can always use your help at registration, passing out ice bottle, a bottle of water, that would be great too. So that would be great. And of course, just send us an email if you're interested, or anything that you can make an impact at info@fightingblindness.ca. We hope to see you there because, as you know, you can make an impact in any way you can. And we've got lots of opportunities for you. So we hope to see you. Thanks.
Sorry, I was on mute. It says, thank you, Susan. Thanks for sharing all that information. And
Sure.
you can find more information on fightingblindness.ca for all those options. So
absolutely.
Okay, so I was going to say back to the show now. Dr. Sheidow, so we have a lot of questions coming in. So I think we'll start off with, there was a few questions around sort of, I would say, potentially prevention or risk of AMD. So the first one was, is there a tendency to develop AMD? Is it genetic? And what do you think about also genetic testing?
Well, and I was going through the questions too, just to have a bit of an overview. And I think a couple of them we probably came back to, but yes, there's certainly a genetic tendency. A while back, a company came out with a genetic test, and what it did was it looked at several different genes that are associated with a higher risk of AMD and tried to give people a risk of them developing AMD. But the problem is that didn't translate into guiding us as far as who you should start on therapy or who should get which therapy. And so there really wasn't a genetic test benefit. That may turn out to change in the future, and it would be wonderful if we could figure out which drug was best for which patient, but that doesn't exist right now. And so I don't personally recommend a genetic test for anybody, because when your optometrist looks in, if they see drusen and or pigment changes, you have macular degeneration no matter what the genetic test says, and it is beneficial to take the vitamins. And so to one of the other questions that came up, vitamins are absolutely a benefit. Follow the AREDS 2 formula, and there is nothing that interferes with any of the injections we take. The vitamins are by mouth. They help slow down the dry degeneration, and they do not interfere with any of the wet.
So you might be taking this supplements or AREDS for dry while also getting injections at the same time.
You should be. Anybody who was started on the vitamins, and that should be everyone with macular degeneration, whether it turns wet or not, the dry is still there. The dry is still a problem. So always continue your vitamins.
Oh, actually, so that's interesting. So you prescribe your patients as soon as they're diagnosed with AMD with the supplements. You don't wait for them to progress at all.
No, because the benefit is to slow down the disease. And basically, there was one of the other questions that asked, I have a strong family history, should I be on the vitamins? One of the things that AREDS in the initial study showed was that if you had just a trace of macular degeneration, there wasn't a clear benefit. There was no harm, but there wasn't a clear benefit to the vitamins. And so one could argue that in a patient who has a family history but no AMD, there's no benefit. And so typically, we don't start people who have a family history on vitamins, but just encourage them to do their once-a-year checkup with their optometrist. And only once you've been diagnosed truly as having macular degeneration would I take them. And that's partly because just taking a regular multivitamin and eating a healthy diet is probably a big part of being healthy in general. And so it isn't the kind of thing that everybody should be on the vitamin.
And I forgot my thought, I might get back to that. But another question along the same lines was about modifiable risks. So somebody mentioned that smoking is the number one modifiable risk. Obesity is sometimes mentioned, sometimes not. It's not a risk factor?
No, smoking absolutely is a big thing, because smoking, and specifically nicotine, is what we call an angiogenic stimulus. And so it helps blood vessels grow. AntiVEGs work against that, but the bottom line is smoking is the number one modifiable risk factor. The watcher who mentioned that is right. Smoking is the worst thing you can do for macular degeneration, but they've never shown really with weight or alcohol to have a similar effect. And so I think right now the answer is stop smoking, but everything else is okay.
Okay. Probably in moderation, but okay.
Yeah.
Yeah. So how about this one? This is a slightly technical one. What can you tell us about the luminescence test that shows the layer below the drusen, which seems to indicate the problem being twofold? Does it open the door to new tests or treatments?
So the text is really what it's called is a fundus autofluorescence. And what we mean by that is if you shine a light at something, and in nature, there are many different plants and some animals that if you shine a light at them, it comes back to the camera a different wavelength, and that's called luminescence. If you shine, in the first place, the ophthalmologists and optometrists use it is looking at the health of a cornea. If you put an orange dye called fluorescein on the surface of the eye and then shine a blue light at it, if it comes back at you green, there are defects in the cornea. And so what this test is doing is it's shooting a white light at the retina and then capturing some of the areas that are intended to show the health of the pigment cells or the absence of pigment cells. And so it doesn't specifically tell you anything about wet, but it is the basis for the treatments for dry. And what I mean by that is that's what is being used by the studies for dry macular degeneration in geographic atrophy to determine how they're helping patients. And so earlier when I mentioned that it was limiting the growth of those patches, that is growth being determined by, as the watcher put it, luminescence, but it's properly called a fundus autofluorescence is the name of the test. And so that test is going to be more widely used by far, but it's going to be more widely used by people like myself treating geographic atrophy. It's not something that everybody should rush off and have. It doesn't indicate anything that the regular optometrist is going to need to get into their office.
That makes sense. So it's more of a monitoring tool if you're on potentially
Absolutely.
some of
If
these
you're on
treatments.
treatment, it's a monitoring tool. If you're not on treatment, you don't need the test.
Okay. And actually, there was a question below. I just want to get to this. That somebody joined late and missed some of the beginning of the session. So if anybody did do this, or if your feed dropped, we are sending out the link to the entire session in an email that will follow up in a couple of days. So don't worry about it if you missed something.
One other thing, Larissa, before you get to the next one, I noticed somebody asking a question about all the injections in corneas. There's 2 points to that question. First is on a positive note, even today, I had some patients back that are for their 10th, 12th, 15th anniversary of injections on a regular basis. Your eye can take as many needles as it needs, and so it's not a problem. But the injections are not being given through the cornea, and so you don't have to worry about corneal damage with the injections. The injections are done through the white of the eye called the sclera, and that's a different area, and so it's not an issue at all for the cornea getting the injections.
Okay, thank you. I did not know that, so it's interesting. There's a question actually about biosimilars. We didn't really touch on those, but I know that is another potentially big area of sort of new treatment coming up potentially for wet AMD. So somebody's asked, how is BioVIS, biosimilar, going to be introduced to patients? And if you want to talk more generally maybe about biosimilars.
It's a real big topic. And so the first thing I would say is biosimilar is going to be told to some people as similar word, the same word as generic, and it's not. I don't think what we want is people listening today to think that a biosimilar is just a generic for an injectable, because it isn't. It's a different process because all of these injections are bioproduced products. So they're like antibodies, and they're made in a lab, and the way they're made is just technically different. A biosimilar, therefore, is not as unsimilar to the original product as a generic would be. So in that sense, they're much more similar in their action, similar in their degree of effect, et cetera. And so I think you're going to see a lot of people being shifted onto them, but it's going to be a mandated thing because the governments are going to come out and say that all people on Lucentis must be started on biosimilar Lucentis from a cost containment perspective. So it is not that BioVIS is going to be better than Lucentis. It is going to be forced on people because if they're on Lucentis, they're going to have to take the less expensive version. And there's going to be several versions of Lucentis probably within the year. And I think in the next couple of years, we're going to see a biosimilar Eylea as well. And basically, it's a way of trying to contain cost. And so the issue really is in order for these compounds to be approved, they don't have to go through the same testing that a new agent would. They just have to show that they're similar in their effect and there's no glaring new side effects. So they haven't had the same testing as the original products, but they have the same mechanism of action and same believed effect. And so what I would say is I expect that BioVIS will work very similar to Lucentis.
Okay. And I guess like as the biosimilars start to come on the market, there's probably going to be more information for patients, but also for clinicians about how the switch has to happen, or if it's a choice and things like that.
Well, and I think that what I hope, and again, we haven't seen the policy and on how it's going to get rolled out, but what I would hope wouldn't happen, and I don't know that it will or it won't, is that in a patient who's successful on Lucentis, they may be very successful on BioVIS. But what we don't know is whether a patient on Eylea will be as successful on Lucentis or BioVIS. And so switching compounds worries me more, if that's mandated, than switching the same compound to a different supplier. It's a different issue. And so the question I think that is more interesting is how are they going to be rolled out and how will it be mandated, not whether it's safe to try. I think it's always safe to try, but it's important to keep a watch on how it works for the individual patient, because that's what really matters. It doesn't matter how a drug works for 100 people. You worry about the person sitting in the chair in front of you at that given instant.
Absolutely. There is actually sort of a question about sort of personal treatment. Is somebody who has wet AMD and has been taking injections every 3 months, and his ophthalmologist has now stated he doesn't have to go now, and he's wondering, I guess, if is every 4 months too long? I guess it's more
everybody has their own comfort level. And what I would say is if I had a test, a genetic marker or something that would tell me which patients were going to be stable for 3 years without a needle and which ones were going to quickly deteriorate, lose their vision, and I couldn't get it back, I'd take the people who could go off. But I've got no marker, I've got no test, I've got no way of knowing. And so that's where the 3-month window comes in for some of us, that we're not willing to take the risk for that patient, especially if that's a monocular patient or a patient with only one good reading eye. We just don't want to see them take that additional risk. There are some people who I think might be very stable at 4 months. The hard thing is how you determine that safely and keep a watch on things. And so there's no right and wrong for an individual. And what we'll probably see more and more is with the newer agents, with the high dose Eylea, we're going to see more and more try to do that.
Okay. There was also a question about, juvenile or infantile macular degeneration, because we didn't talk about that at all. We talked very much about age-related macular degeneration.
It's not the same disease at all.
Okay. Is that Stargardt's disease?
It's Stargardt. Stargardt's or fundus flavi maculatus. Those are true genetic diseases where we actually know the gene. And although we call it juvenile macular degeneration because there are some similarities in the look, it's a different process, a different problem. They don't get wet blood vessels or wet degeneration at the same rate. They can develop it though. And it tends to be much earlier in its development of the atrophy of the center. But that I'm aware of, that the new agents coming for geographic atrophy haven't been tried in the Stargardt's patients. And they may, but as of right now, they haven't been. But it truly is a genetic disease. And so I think what you'll see is that that's where many different companies are looking towards gene therapy. So either replacing the gene that is deficient in Stargardt's or something similar to make a similar product is where they're aiming for Stargardt's. But they're different diseases, so I like to separate them out and put them in different boxes.
There were a couple of other questions actually about Stargardt. So one about if AREDS is recommended for Stargardt's. Somebody also asked about vitamin A. I'm not too sure if this is within your area of expertise. And I think you did mention about the treatments being different at this point.
The vitamin A goes way back to the days when we used to encourage high doses of vitamin A for people with inherited diseases like retinitis pigmentosa. The problem is that vitamin A, as one of the fat-soluble vitamins, you can have too much of it. And so, what I say to some of my patients sometimes is more of a good thing isn't always better. And so it's not that vitamin A supplementation is bad, it's that you can have too much of it. And because there isn't any, I think, clear indication that too much vitamin A is better for your eyes, at least from a Stargardt's and AMD perspective, I don't usually encourage it. Could AREDs help Stargardt's patients? There's no clear evidence of that, but I certainly would never say it's harmful. So not smoking, taking AREDs in a Stargardt's patient, if it makes them feel better about helping themselves, by all means. One of the things we often forget is that one of the most beneficial things in an ARED supplement is the lutein and zeaxanthin. They're antioxidants. And what we all forget is eating a healthy diet with lots of brightly colored vegetables is good for all of us. It's hard to get into our lifestyles, but that doesn't mean it's not good for us. And so sometimes just being a little cognizant that a little bit of dietary changes and stuff is all good too.
Okay. Somebody was asking that they are having more difficulty with glare lately, and they were wondering if this was due to AMD or cataracts.
Much more likely to be from their cataracts, not their AMD. Glare can happen after cataract surgery, before cataract surgery, but it's not really an AMD thing.
And we actually had some questions beforehand, so I'm going to get to a few of these as well. So Deanna asked, what is the difference between Vabysmo and Osodex, and if there was a benefit of one over the other, and also about side effects?
Two totally different products. Osodex is a compound which is a time-release form of dexamethasone, which is a steroid. And so Osodex is used in diabetics, in people with inflammatory conditions we call uveitis, and it's used in people with blocked veins or retinal vein occlusions. It treats the swelling, but it's treating the inflammatory part of swelling. So anybody who's had a swollen knee or a swollen ankle, they may have had an injection of steroids in their knee. Osodex is essentially a souped-up version of an injection of steroids. Works wonderfully well in some patients, but it doesn't really have a role in macular degeneration.
Okay.
Whereas Vabysmo is an anti-VEGF, so it stops the vascular endothelial growth factor. And it also has the side benefit of treating one of the other factors called ANG2. But basically, Osodex and Vabysmo, or any of the anti-VEGFs, are very different agents.
Okay. And so you wouldn't prescribe necessarily Osodex to patients with AMD, but you might do it, for instance, for diabetic macular edema. Okay.
Yeah. And so the place you'll probably see Vabysmo and Osodex talked about in the same patient is probably in the patients with what we call diabetic macular edema, because Vabysmo has been approved for diabetic macular edema, as Osodex has. And so Osodex hasn't been approved for AMD because it's never really been one of those things that we look to.
Mm-hmm. Okay. So Merv is asking actually if there are any treatments for scar tissue from wet AMD, because his eye is stabilized, which is wonderful, but there is a blurry area from scar tissue now.
Not really. For most patients with AMD, once they got a scar, that scar is going to stay there. If you tried to surgically extract it, more often than not, you do more harm than good. And you put at risk all your peripheral vision and the vision you do have. And so the smart thing is to leave the scar alone.
Okay.
Hope that it never develops, but leave the scar alone.
Okay. So so if there is the scarring, unfortunately, there aren't any specific treatments right now for that. This is an interesting question. Is it possible to transplant an eye?
No.
Okay.
We can transplant a cornea. It's the most successful transplant of any body tissue because it doesn't have blood vessels. In the retina, they haven't been able to transplant the retina or pigment cells and have them function right, because your retina and the pigment cells are essentially part of your brain. And until they can transplant somebody's spinal cord or a piece of brain, you're stuck with the same thing with your retina. And the eye is just, it's just the house that holds your retina. I know my ophthalmology colleagues will disagree with that, but I think of the retina as everything, and everything else is just there to make the retina work.
Yeah, I'm sure there would be some clinicians.
There'd be a little discussion on that, but I'll take that hit. Yeah.
Okay. And there was actually a second part of the question about stem cells. And I know there have been some clinical trials right now looking at replacing RPE cells, I think specifically in dry AMD. Do you have any
Yeah,
information
the
on that?
idea with stem cells is because both retinal photoreceptors and the RPE are end of the line cells, meaning when they die, they're dead. They don't reproduce and replenish themselves. The problem is that if someone loses photoreceptors, as happens in retinitis pigmentosa, or loses RPE cells as in dry macular degeneration, how can you get new ones? And so that's where they've tried stem cells. Stem cells are cells that are able to change and develop into something new. And so it's not that they are a pigment cell, it's that they have the potential to change themselves into a pigment cell or a skin cell or a cornea cell. And with the right stimulus, if we could get them to turn into the pigment cells, we might be able to replace some of the damaged cells. So what they're working on right now is trying to transplant stem cells under the retina to create a new layer of pigment cells. The problem is getting those cells to first live, second, not cause an uncontrolled growth, which we call cancer, because any cell that continues to grow without bound is a cancer. And then on top of that, we then need the photoreceptors, the actual seeing cells, to start working again. And so there's multiple steps in this. And so for those people who are hopeful, I am hopeful as well that stem cells may be a treatment of the future. But what to be careful of is that some clinics, not in Canada so much, but in other parts of the world, will tout themselves as offering stem cell therapy to the eye with an injection. And sometimes injecting stem cells into the eye, which has been done into the vitreous cavity, like we do with that, can lead to scarring and problems that weren't predicted in actual visual loss. And so I think that although I believe that stem cells will someday be a therapy and a hope, it's still in the very experimental grounds and really needs to be kept to researchers, because it's important to do this right and make sure we're helping, not hurting.
Mm-hmm. Absolutely.
But I really do believe in them.
Mm-hmm. I feel like it's always the number one thing that I hear from doctors. It's all about do no harm, first and foremost. This was an interesting question, I thought. Is it known if tests that the eye specialists use to monitor AMD or other eye diseases can cause harm to the eyes?
So right now, I would say that there's none of the tests that are routinely done that I know of that do any harm. The one for wet macular degeneration that most commonly done is an OCT, and that's basically a flash of light. A fluorescein angiogram, which is a dye that's put in the veins and then photographs are taken. The dye is not like iodine or any of the dyes that can harm your kidneys, and so it's not a problem. And an actual true allergy to fluorescein is quite rare. And the fundus autofluorescence that we talked about earlier, again, is a light. It's not a harm. So none of the tests that we're doing are harmful, no.
Okay. This is another sort of technical question from Jake, who says that some doctors use a needle in the eye for freezing and others wipe something over the eye or use drops. I don't like the freezing needle, but they give me the drops not carefully. So when I get the real needle, I do get some blood and lingering pain. And so I think he's trying to clarify about the different types of freezing methods.
And I saw Jake's comment, and I should have brought it up earlier. So separate out a couple of things. One is the freezing and the other is the blood. Anytime you stick a needle through an area that has blood vessels, you can hit a blood vessel. I can't see them all, nobody can. And so anybody who said they've never had blood outside the eye before hasn't had very many injections or has been really, really lucky. But the blood on the outside, whatever you see when you look in the mirror, is of no consequence. You will be less attractive for a week or 10 days while that bruise, because it really is all it is a bruise. It doesn't do any harm. So the blood on the outside of the eye is not related to the freezing at all in that sense. It's related to the needle. But to Jake's point, some people believe that you just put drops on for freezing. Some people put a little pledget, where it's a little sponge, and then they let the freezing sit in that. And others put a needle before the needle, a needle of freezing. I personally only use drops because I figure then it's only one needle, not two, but everybody's a little different. And there's no right and wrong in how you make people sing. Whenever you do an injection, though, it is not that It should never be a painful experience, but it is never not noticeable. So feeling the injection is quite common, and I would say expected. It shouldn't be the worst pain of your life, but it's quite common that you will notice something even when you get good freezing. And so and often some of that is the pressure. You're injecting a liquid into the eye that will naturally put the pressure up a little bit, and it takes a few minutes for the pressure to come back down. But most of us won't then stick another needle in to let pressure off, because then you're getting double the risk of infection. And so the smart thing is just wait a few minutes and the pressure comes back down, and it's just a little safer.
So just because you mentioned pressure, is there any risk if you have AMD and glaucoma that the injections have an impact on glaucoma progression?
There's been a lot of talk of that, and in some places that use a lot of Avastin, there was some discussion whether that may have been a risk, and certainly the question's still out in that. What we haven't seen is that the injections clearly cause any progression. I think the times that I worry are on the people who have really severe glaucoma. So they've had glaucoma surgery or have done a lot of damage to their optic nerve, because it's not the short period of time when the pressure's up, it's a long period of time that's more worrisome. But in those people that have damaged optic nerves, it may be better to either use a slightly lower dose or let a little bit of fluid off. But for the average person who's on regular drops without much damage, the answer is no. I don't think you stick a needle in there and do extra risk.
Okay. So this is actually moving away from injections and asking about laser treatment to slow the progression of AMD. So Terry is wondering about your opinion, because they have been taking this for over 2 years, every 3 months, and it does seem to be slowing progression down significantly.
That's a loaded question. I can only put one foot in my mouth at any given time. Back a few years ago, there was 2 studies that clearly showed that laser for dry macular degeneration to treat drusen clearly increased people's risks of getting wet macular degeneration. And so there was no doubt, as of those 2 studies, and that's probably more than 10 years ago, that laser in people with macular degeneration is harmful, not helpful. And so we shouldn't be lasering. And it's gotten to the point where for most retina specialists, if a patient has diabetes and might benefit from a little laser, and they've got macular degeneration, many of us will shy away from lasering because we don't want to stimulate the potential for wet. When they experimentally try to create wet macular degeneration years ago in animals, the way to do it was to laser somebody's retina. And so the answer is people with macular degeneration really shouldn't be getting laser.
Okay.
It's probably a little too blunt an answer, and it may not apply to that person's situation. There may be other reasons, but I would be very skeptical that most of the patients listening today should not be getting laser.
Okay. I think that was clear. So in terms of, there's a lot of questions about supplements. For instance, Pat asked about, is extra lutein worth taking, or is there enough of ARADs? Somebody else was just asking about what type of supplements do you take? I don't know if there's a general answer, or if it's a person by person.
I think the general answer is getting close to the doses in the AREDS 2 formula would be good. It'd be wonderful if FBC could post those compounds, but the two name brand products are Vitalux and Ocuvite. Now, I'm sure the major pharmacies all make their version of it, and many of the other products are very similar, but the idea is, when we first did AREDS 1, we used to use beta carotene. And so everybody assumed that adding lutein, which was similar to beta carotene, would only be better. And in fact, those 2 agents didn't help each other. They worked against each other. And so to the person's question, should you take more lutein? That's never been shown to be helpful. Take the dose that's in the AREDS 2 formula, and that's enough.
Okay. I think that's a good suggestion from Fighting Blindness Canada to post the composition, because we do get a lot of questions about that as well. So there was a couple of questions about sunshine. So is bright sunshine a problem for AMD, and or should you be wearing sunglasses all the time? Is there a risk about sun?
There's lots of, and they're not anecdotal studies, but there's lots of studies looking at populations over the years where they looked at groups of people that got exposed to more sunlight and less sunlight. And the question was always, does sunlight have a clear progression of macular degeneration? And I think that the way it's come out now is the answer is no. And similarly, that cataract surgery doesn't cause a progression of your macular degeneration. And so you also don't need to spend money on blue blocker lenses and things like that. But that said, I tell my macular degeneration patients that a good pair of sunglasses is helpful, because what happens is that if you think about macular degeneration eyes as being a little less robust, a little less strong, when a person with macular degeneration goes outside on a sunny day, they get a blast of sunlight, and it takes time for the pigment cells to clean up after that blast of sunlight. And so for a period of time, they won't see as well. And similarly, when they come in, they've been blasted by light outside, they don't recover as quick. And so it's always good to have a good pair of sunglasses that you put on before you go outside and you take off after you come in, because it'll just generally help you see better.
Okay.
And it doesn't hurt your eyes, it just hurts your vision, if you know what I mean.
Yeah. We've actually had a few questions about myopic choroidal neovascularization, which I hadn't heard of before. So somebody just wanted you to speak about it generally, but there was also a specific question about that they're using anti-VEGF treatments for CNV, that will in the future there likely be different treatments specifically for myopic CNV. So,
I mean, there's about 43 different reasons why you can grow a blood vessel under your retina at the back. We talked a minute ago about Stargardt's, less common by far than macular degeneration, but there's a whole host of them, and myopia or nearsightedness, especially in its extreme form, can lead to a blood vessel growing. Essentially in myopia, because the eye is typically bigger, they can get little cracks in the pigment layer. And just like in macular degeneration, where a damaged area lets a blood vessel grow, the crack in the sidewalk example, in myopia, a blood vessel can grow through that crack. So what I sometimes say to patients, and it's common in myopes and in people that have been exposed in childhood to a fungus called histoplasmosis, that in all instances, you've got a blood vessel growing that is being pushed forward by my fertilizer, my VEGF. And so in all of these people, anti-VEGF agents help. The problem being getting them started, because the more vision you lose, the less vision you get back. But the anti-VEGF agents, and not specifically one kind, any of the anti-VEGF agents work for myopia, they work for histo, they work for all these conditions. The big difference is because they have generally a healthier RPE, they tend to be people who you can treat and then get off therapy, whereas people with macular degeneration, you typically, as I mentioned, keep on therapy for life. So myopic CNV right now is something which I treat the same way initially as AMD. I just am more apt to stop the therapy once they're stable.
Okay. And once they're stable, will
they need to be monitored for a little while.
Okay. Okay. There was a couple questions about pain after injections and infection. So is there anything to prevent infections after injections? And if someone has extreme severe pain after injections, which they think might be caused by the betadine or other drops, can this be helped?
So the betadine is, betadine and chlorhexidine are two different antiseptics. Betadine or iodine essentially has been the long-standing best product, but it also is hard on the cornea in the sense that you get gritty, scratchy, burny eyes for a couple of hours, and some people really do dislike it, but it really helps from a safety perspective. And so I would say that everybody has to have some kind of an antiseptic given beforehand. Even though it's irritating to the eyes, the risk of infection is far, far, far greater, because all of us, if you were to swab my eyelids and the tears in my eyes, you're going to grow bacteria. And so passing a needle through that tear is absolutely the biggest risk you have. And so using betadine or chlorhexidine is important. Some people temporize that by flushing the eye out after the injection, which I do. Some people will get a bottle of any tear product and use it several times after the injection to sort of help lubricate and rinse out the iodine or chlorhexidine. And I encourage them to do whatever works for them. But it is really important to remember that safety first again, you need one of those antiseptics to lessen the risk of an infection.
Okay. I think that's a good practical tip though about the tears, the artificial tears to help wipe away if it's painful. So we've got a question from someone who says they were told that their wet macular degeneration is at a point where more injections aren't providing any benefit. So I think they were wondering about what does this mean, and is there anything else that they could potentially do?
Well, the natural evolution of wet is that if you let the blood vessel grow long enough and or the blood and fluid be there, it'll kill off all the seeing cells, the photoreceptors, and it will end up as a scar. And so if you've gotten to the point where you have a scar in the center and no significant central vision, and I don't mean no vision, if you look at some of these patients, they can only read the big E on the chart, or maybe they can't read any no letters on the chart. They still have wonderful peripheral vision, and so they still have vision. But the injections are meant to protect, well, first of all, to try to get back some central vision, and then secondly, to protect central vision. So if you don't have central vision to protect, why get a needle that risks an infection or a retinal detachment that could affect your peripheral vision? And so what your ophthalmologist is saying is, I'm not making you better. I don't think I'm making your life better. And I'm putting you at slight risk for no real benefit. So that the smart thing is to keep the vision you have by doing nothing, and let's watch the other eye. Okay. And so it's really meant as a safety thing, that if there isn't something to protect, don't keep sticking a needle in there.
Okay. We are rapidly running out of time, so I'm going to ask one or two more questions, and then I think we might have to get to some of these other questions afterwards. So there was a couple of questions about cataract surgery, and if you're going for cataract surgery, do you have to be aware of anything? Does it increase the risk of progression of AMD?
No. You just need to remember that I wouldn't want to stick a needle in someone's eye the day before or the day after they had the cataract done. And so you work with the cataract surgeon and the patient to change the schedule. But we don't have proof that doing a cataract expedites the development of wet or dry. And I tell people that since we're all going to get older, we're all going to get cataracts. Once they start to affect your vision, it's a treatable thing. Get rid of the cataract, get the best vision you can, and that way we can monitor your macular degeneration better. But at the end of the day, there's no reason to prevent people from having cataract surgery.
Okay.
And nothing extra to watch.
Okay, fantastic. And it's sort of related, not related. You might have answered this a little bit already. So someone has recently found they have macular degeneration and recently found they also have glaucoma, and their doc wants to use the laser for glaucoma. And so I think they were wondering if it was safe because they have AMD. Different
laser. Okay. Do your glaucoma laser for sure. And it's also a different laser that is the laser used after cataract surgery. Both of those lasers are not anywhere near your retina, totally safe, go ahead. The laser I was speaking about earlier was a laser of your macula, which is part of your retina. It's part of the central bullseye. You don't want to burn little holes in your retina if you have macular degeneration, but the laser for glaucoma, totally safe. The laser after cataract, totally safe.
Okay. Glad I asked that one. I thought I knew the answer. I was wrong. So, and the last one, we have had a lot of questions about ARAD, so it's another one about that. So someone was saying because of another disease, their husband can only take one tablet a day. Otherwise, he gets too much vitamin C because of kidney disease. So is he still protected enough?
Well, no, and it's a great question. And I saw the one earlier about vitamin E. Mm-hmm. And they're similar but different. Vitamin E is different because, and I'll come back to the vitamin C, vitamin E is different because it's also a fat-soluble vitamin. And there was some concern that too much vitamin E was actually increasing people's risks of other problems. And the problem was that the studies of too much vitamin E and that compared too much and too little, AREDs fell right on the number in between. And so what's been shown in the AREDS2 study is that vitamin E wasn't a problem in the dose that AREDS2 was giving. And so the vitamin E that you're getting is safe. For vitamin C, it's less of an issue because vitamin C is peed out by the kidneys. So it's a water-soluble vitamin. It doesn't have the same toxicity that vitamin A, D, E, and K can have. And so I'm not saying go out and take a mountain of vitamin C every day, but I'm less worried about vitamin C, even in somebody who has kidney problems. And so the answer to the question is, if your kidney doctor feels that too much vitamin C is a problem, follow the recommendation, because taking one tablet more may not cure, it's not going to cure your macular degeneration anyway. And so there's no real answer to, is he protected enough? I can't say he is or he isn't. I'm less worried about extra vitamin C in people in general, but I would just follow the recommendation or ask the person a little more about it, because I don't think one tablet versus two is going to make a world of difference either way for your kidneys or your eyes.
Okay, I think we're going to have to end it there, although I feel like we could have gone on for another half an hour, but I'm very conscious of your time and everybody else who is watching. So thank you so much, Dr. Sheidow, for joining us. This was a really wonderful session.